Is it
How are
morning there
you?
yet?
It's a pleasure to be here. Hi everybody. Thank
Hi.
you for organizing this wonderful conference, man. Nina is great. That's a tough act to follow. I don't know.
I think we're all excited to have you here. So
She's a
without much
force of
ado, I think,
nature.
yeah, I guess so. But thanks for joining the session. I know it's pretty early for you there, maybe, but we will start right away. So a little bit of introduction of us. I'm Shayan Datta. I'm a certified day life coach and a member of the team as well. As you would be aware, and everyone who has joined the session, that DLife is the first and only award-winning low carb platform founded by in 2014 by Anup Singh. Like Anup itself is a icon, is a pioneer, is a path breaker. He's a silver medalist from IIT Roorkee, one of the prestigious engineering institutes in India. And also he was awarded one of the icons of India way back when he started this movement. In 2012, he started the protocol of 100 grams of carb per day, which essentially allowed Indians not only to follow LCHF protocols, but also allowed Indian vegetarians to reverse diabetes. Arun itself is a prime example, not being vegetarian, but otherwise how diabetes can be reversed for 14 years. And today is the anniversary that Anup is celebrating, and he will come and join us in some time as well. We also launched in 2021 the DLife Metabolic Health Diploma course. Again, some first, it provides now 144 CBT course hours. I don't think anyone else provides so many course hours. And also from an Indian perspective, we have got a government body called NSDC partnering with us and providing a partner certification, so that provides more authenticity to the course. Again, the only one of its kind. And this session or this conference is just an extension for the last 3 years and a validation of what we have been doing globally, being organized by Mr. Sashikant Yankar and Anup. And again, welcome to you to the session, and we will discuss a lot more. But before we go there, I also wanted to introduce my fellow colleague and co-host and dear friend, Dr. Mandar Gadre, who is also a certified D-Life coach and now a famous author of a book in a regional language. So maybe we can talk about that later. But going forward, to all the viewers here, while this might seem a little small, but customarily a little bit introduction about Dr. Robert Lufkin. He's a physician, a researcher, an author specializing in metabolic health and longevity. He's a former UCLA professor, and he is known for challenging medical conventions in a bit unconventional manner through low carb nutrition, through lifestyle changes to combat chronic diseases. His book, Lies I Taught, is in medical school, exposes flaws in medical education, and we'll talk a lot about it today as well. But he does promote a metabolic first approach when it comes to health. Doctor, in this session, we will touch upon and like to touch upon the medical myths that are flying around today across the globe in India or wherever we are today, right? Myths often start from stories. They might not be the right stories, but they eventually often repeated and often told generation after generation that they become gospel truth. And through this session, we would like to understand what is your take on those myths, how you have kind of debunked them and demystified them, and how do we approach the various facets of it which does real harm to the society and the civilization. And obviously, there's a lot more that you can offer, and we were eager to know from you. In the interest of time, if you permit, we will just go straight ahead and jump into some of the things that we really start wanting to know from you and eager on the same.
Sounds great. Let's do it.
Okay,
This will be
great.
fun.
I've been monologuing, so I will try to stop that as soon as possible. But doctor, first, talking about your book, and we'll start there. What was that one eureka moment that you had, which kind of motivated you, which kind of pushed you, and that light bulb moment which started, which resulted in this magnificent, globally acclaimed book?
Yeah, great. It's a great question. The book is very critical of sort of Western allopathic conventional medicine, and I'm obviously part of the problem. I mean, as you mentioned, was a professor at UCLA. I'm now a professor at the other medical school in our town, USC. So I'm still part of the problem. Um, but even though the book is critical of Western medicine, I want to say that there's still some great things that allopathic medicine offers. Like today, if I get hit by a car out in front of my house, I want to have access to, I want to have blood transfusions. I want to have surgery, get my spleen removed if needed, and my bones, my fractures set, that kind of thing. And in fact, allopathic medicine was truly changed our lives in the 20th century. Those of us who were alive then, it transformed the world, healthcare, largely through public health measures, but in infectious disease, but the pills and the surgeries, the technologies that were developed truly, truly made the world a better place. And the problem is, and what the book talks about, is now in the 21st century, where we're, a quarter of the way into it as of this year, we're facing literally a tsunami of so-called chronic diseases that, although they were present in the 20th century, they're now present in biblical proportions and unprecedented in history. And these chronic diseases include everything from obesity, diabetes, cancer, heart disease, stroke, Alzheimer's disease, mental illness, hypertension. And the problem is when Western medicine or allopathic medicine applies the same pills and surgeries that were so effective in the 20th century to these chronic diseases, while they may help with the acute symptoms and keep people from dying immediately and controlling the symptoms, in most cases, they don't get to the root cause. They don't address the underlying cause, and the disease continues to progress and gets worse and worse and worse. And that was really the challenge. And the wake up call for me was I'd like to say, hey, I wanted to make the world a better place, but no, it wasn't like that at all. I was minding my own business, being a professor, doing my own thing, when suddenly I came down with 4 of those chronic diseases myself, 4 of them. And I went to my doctor and they prescribed medicines for each one of those diseases, which is what, the allopathic approach is. And, I didn't know any better. I said, hey, what about lifestyle? Is there anything else I can do? And they go, nah, none of that really works. You're going to be on these pills for the rest of your life, so get used to it. And at that point, I had, young children in school. I still have young children in school. And I realized this wasn't going to end well. So it largely out of self-interest, I was forced to re-examine my own personal beliefs and the beliefs of, many of my colleagues that are still teaching about these chronic diseases and what actually causes them and what you can do to improve them. And I realized there's a huge body of research and evidence-based, controlled trials in many cases that I wasn't aware of, and that really strongly show that lifestyle changes can work. And long story short, I began doing relatively simple life of these changes myself and changing my own lifestyle. And I was able to reverse all 4 of the chronic diseases to the point my doctors couldn't believe it. They thought the labs were broken or something. And I got off all medications. And now I've made it my mission to help other people take back their health and hopefully not make the same mistakes that I did. And that's what I'm working on now, to get this message out.
Wonderful, doctor. That's enlightening. And it's interesting that you talk about that, how you took it upon yourself to kind of, look at your own health and then get the solutions and then pass it upon. It's a wonderful segue, because that's what Day Life has also been about. Like Anup started doing it for himself and then kind of, ensure that this is a mission of his life to pass it on. Ira also did the same thing. And a lot of us have been blessed to have that kind of a community here today to kind of, I won't say medicate, but self-analyze what we need from life, which is obviously health, and then move forward. You spoke about 21st century and prevalence or relevance of it. If you could throw some light upon what are the kind of lies or myths that are being taught today in medical schools. We have a huge number of doctors here as a part of DLife community and also part of the audience. They would like to know what kind of lies are being taught today in medical schools, and if you can talk about and discuss about it.
Yeah, I mean, kind of at a very broad level, kind of a wake-up call for me was even, hey, I'm a doctor, but I realized that doctors don't make me healthy. My doctors just make me less sick. And if I want to be healthy, that's something that I need to do myself as a patient, and that involves lifestyle. And unfortunately, fortunately, lifestyle is something I get to choose every morning when I wake up, what I eat, when I exercise, and that's something no doctor can do for me. The other kind of broad lie point that would really change my way of thinking is, as a physician, I used to think of diseases as kind of binary things. Either you have diabetes, when your A1C gets to a certain point, or you don't. Either you have Alzheimer's disease or you don't. And what I didn't realize, that all of these chronic diseases that I just mentioned, there's very strong evidence that they really don't start the moment the doctor diagnoses them. In other words, they start years to decades before the doctor finally says, oh, you forgot your keys, you have Alzheimer's disease, blah, blah, blah. And the point is, if I wait until the doctor tells me I have one of these diseases, I've missed a tremendous opportunity for prevention. And that's the motivation for adopting these lifestyle changes, even before the doctor tells me I have the disease, because the diseases I mentioned, those chronic diseases, interestingly, are the same diseases that you and I and all of our listeners statistically will die of. I mean, everybody dies of something, right? Nobody gets out alive, right? So we're all going to get one of those diseases sooner, hopefully later rather than sooner. But the idea is to push it back, push it back the point when we get it. And by adopting these lifestyle changes, there's evidence that by improving our lifestyle, we can delay the onset of whatever disease it is that's finally going to take our lives. And we can push it back and have a longer health span and a longer lifespan in many cases too. So it's a really interesting concept that I hadn't thought of before, but the fascinating thing is the same lifestyle choices, the same nutrition choices, the same sleep, exercise, stress choices that help me decrease my risk of Alzheimer's also decreases my risk of diabetes, and also heart attack and stroke and mental illness and polycystic ovary disease if I were a woman, and all sorts of things like that. It's amazing, these common lifestyle things work across the board. And I think that message, certainly isn't being communicated well in medical schools today. And many doctors, many of my colleagues, frankly, don't believe it.
Interesting. And I just one question before I pass it over to Mandar is, you spoke about that doctors don't believe it. Is it largely because they don't want to believe it, or they're not taught to believe it?
It's a great question. It goes back. I mean, my mom was a dietitian, so I was raised in a family with nutritional advice, at least with the idea that what we ate mattered. It affected our lives. Unfortunately, the advice I was given, which was the standard dietitian medical advice, was wrong and unhealthy. It was to eat a low fat diet and a lot of seed oils and all this kind of stuff. But the notion that nutrition mattered really resonated with me. But nutrition science is, I would go to the conferences with my mom occasionally, and the dietitian conferences were sponsored by Coca-Cola, McDonald's, all these, patently, obviously unhealthy organizations. And in fact, nutrition education is paid for by junk food makers, by large food makers, largely junk food makers. Well, with medical education, it's even worse that medical education is paid for by pharmaceutical companies largely. They dictate what's taught in medical schools. And pharmaceutical companies have a vested interest in making money from people with chronic disease, and so there's that effect. And then by funding research, the same pharmaceutical companies influence the way that research, the types of research that's done and the types of research that's published. And even to the point where in some cases, negative research is suppressed. I mean, I used to have grants from large, my lab had millions of dollars of grants from pharmaceutical companies, but some of the research stipulations, the contract was, you do the study, which we do, but at the end of the study, before you publish anything, we have right of first refusal. In other words, if we don't like the paper you wrote or we don't like the results, we'll kill it. And so there's that kind of influence. Then we have trusted medical institutions, which should be trusted health sources, things like the American Heart Association, which advocates the use of seed oils on their website. And I believe seed oils are pro-inflammatory. They're unhealthy for all sorts of reasons. But one thing they do is they slightly lower LDL cholesterol. And the American Heart Association is sort of fixated. Their main point is about LDL cholesterol. And so they advocate canola oil or corn oil as a heart healthy food choice. And you think, well, why would they do that? Well, one, that lowers LDL slightly, but then if you look back in their history, the American Heart Association was largely funded in the middle of the 20th century by a multi-million-dollar donation from a large conglomerate company called Procter and Gamble. And Procter and Gamble, at the beginning of the 20th century, took some machine lubricants that were developed originally for German U-boats in World War I, and they found out that they tasted okay and humans could eat them, and they rebranded it. They called it Crisco, and it was an industrial oil, one of the first seed oils, and that was the funding source for the American Heart Association that still, I believe, is influenced by these things. And you go on and on. The American Diabetes Association, which is the main voice in diabetes therapy in the United States, but also worldwide. People look towards it. Type 2 diabetes, as we know, is exploding. Almost half the people in the United States are pre-diabetic or diabetic. It's unheard of. The American Diabetic Association recommends on their website certain recipes because diabetes is all about nutrition and everything, and the recipes include sugar in them, fairly liberal amounts of sugar, in my opinion, but their recommendation is just to cover it with insulin. In other words, to control the sugar add more insulin, which actually works. It's one of those acute things that you do. It keeps you from dying of hyperglycemia and it controls the acute event. But the problem is controlling diabetes, type 2 diabetes with insulin doesn't control the long-term effects downstream. And we all know what those are, right? The number one cause of surgical amputations is type 2 diabetes. Number one cause of kidney failure, renal dialysis is type 2 diabetes. Number one cause of retinal blindness, and on and on and on. Alzheimer's disease is called type 3 diabetes for good reason, because of the metabolic effects on glucose metabolism. But anyway, back to the American Diabetic Association, right where the website has this recipe, they list one of their sponsors that essentially is paying for that promotion, and the sponsor's DaVita Corporation. Well, who's DaVita Corporation? What do they have to do with diabetes? Well, they're a dialysis company, one of the leading renal dialysis companies. And like I said, the number one cause of renal dialysis is type 2 diabetes, which in my opinion is made worse by people who put sugar on their food and control it with insulin rather than adopting a carbohydrate restrictive diet, which will actually reverse the type 2 diabetes in majority of patients and stop the progression onto renal failure and all these other things. So it's sorry for the long answer to a short question, but it's widespread in my opinion, and it's everywhere. It's woven into the fabric of our medical industry. And I want to say I don't believe anybody gets up in the morning, for the most part. I think, healthcare practitioners and most human beings, we don't get up in the morning and say, I want to harm someone, but it's so woven in our system that we're forced into situations where we make judgments that do have harmful effects, in my opinion.
Thank you so much. Mandar,
Yes.
over to you.
So, yeah. So, talking about things, woven into our system. So, you have talked about the obesity lie in your book, right? So, what is that obesity lie? And isn't it just taking in, less calories than expending more?
Yeah, I mean, the obesity lie is the advice that's still given today at my medical schools and to people who are overweight, and that is, if you want to lose weight, just exercise more and eat less. And how's that advice working? Well, today in the United States, most adults are either overweight or actually obese. So, it's not working very well at all. And why is that? Well, first of all, exercise. There are many, many, many health benefits of exercise. We all know that. Unfortunately, weight loss is not one of them. In other words, because it's very hard. How do we work up an appetite? Well, we exercise, right? And the caloric consumption of exercise is actually relatively small compared to what we can eat if I eat a sugar donut and get 500 calories, it's going to take me a long time to do that much exercise to burn it off. So the equation doesn't really match. So exercise more is bad advice because it makes you hungry, it makes you eat more, and it doesn't really, it's not an effective way to lose weight. So how about eating less? Well, that makes sense. Obviously, calories make us fat, right? So just eat fewer calories. Well, it's actually, I think a better message is because of what we know, what your audience knows about the 3 macronutrient groups: fats and proteins, which are required for life. If we don't eat those, we die. And then carbohydrates, which interestingly are not required for life. And there's several human populations that consume very few carbohydrates historically, and they're fine. These 3 food groups affect the fat storage hormone, insulin, very, very differently. So fat and protein stimulate insulin very little, but carbohydrates stimulate insulin a lot. And insulin does many, many things, but one of the things it does is it tells the cells to store fat. So the message is that a calorie is not a calorie. In other words, calories from fat and proteins get a very different response in the body from calories from carbohydrates. So as an example, if I eat 100 calories of carbohydrates, a few potato chips, I will stimulate insulin. That energy, a large proportion, will go to fat. I'll be hungry again, and I'll likely consume the rest of the bag of potato chips. If I eat 100 calories of hard-boiled eggs, hard-boiled eggs are largely fat and protein, very, very little carbohydrate. If I eat 100 calories of hard-boiled eggs, that will go to energy that's available to my body. It largely won't be stored as fat. and I won't be hungry again. And I probably won't eat the rest of the dozen of hard-boiled eggs, but you can bet most people will eat the whole bag of potato chips. Just because, so 100 calories of carbohydrates is treated very differently from 100 calories of fat and protein. So to lose weight, rather than just eat less, which doesn't really work, just eat fewer carbohydrates. So you can eat the same number of calories, but if you eat fewer carbohydrates and replace those calories with fat and protein, you'll be less hungry, you'll be less likely to eat more, and you'll store less fat. And that's why certain diets that low carb diets, ketogenic diets, these diets are very effective at weight loss, because they control the appetite and all sorts of effects like that. So those are eat less, exercise more. Those are both very wrong for all sorts of reasons. Yet that is the gospel teaching that the dietitians like my mom still teach, and that healthcare professionals is the advice they still give to obese people. Now, the whole GLP-1 agonist is a whole nother story, and interestingly, in the United States, it appears after the obesity epidemic has been exploding since the 1980s in the US, it's too early to say for sure, but there's some signals that actually the number of obese and overweight people may be changing. Time will tell, we'll see. But this particular drug is really a game changer. It's unlike anything else for weight control, and it has a lot of interesting effects on lifestyle too, and addiction and alcohol, and even eating junk foods. But that's a whole nother conversation.
No, thanks for the multifaceted answer. So I'll extend that to the other big lie, right, that you mentioned on type 2 diabetes. So why is it not chronic progressive, and how we should really look beyond just managing the blood glucose?
Yeah, that's a great question. I think the problem the way that treatment is offered to patients with type 2 diabetes, in my opinion, is that the main treatment is certain drugs, starting with metformin and all, and then transitioning into insulin to basically control the high blood sugars, which if high enough can be fatal, no question about it. These drugs are life-saving, an acute event for diabetics. The problem is, in the studies, this isn't my idea. There are, peer-reviewed studies that have shown this, that controlling the glucose with insulin in diabetics for most of the chronic complications doesn't really affect them. In other words, it's still a chronic progressive disease when you control it with these medicines. You're keeping people from dying from hyperglycemic effects, but you'll die of a heart attack, you'll die of a stroke, you'll have Alzheimer's, there are other downstream things you'll die of, renal failure, et cetera, et cetera. So what isn't being offered, or at least offered with the correct messaging so that people actually accept it, is the idea that you can either do the drugs and all and manage it and have a chronic progressive disease that will eventually kill you, or you can do things with your diet, primarily diet, but lifestyle also, that will, in controlled studies with Virta and other companies, other projects have shown that the majority of patients, when they adopt this healthy lifestyle, largely diet again, by lowering carbohydrates, they're able to stop the progression of the type 2 diabetes and actually put it in remission, where in the majority of the cases, patients actually go off the medications and they've essentially stopped the disease. So it's no longer a chronic progressive disease. Their risk of amputations and renal failure and all is not what a type 2 diabetic has. So the issue is, why isn't this promoted much more to patients? Because it's truly life-saving. versus an alternative of these drugs for life, and then ongoing complications with all these other chronic diseases that will eventually kill you and cost the healthcare system a great deal of money as well.
Yeah, I think that's going to be very insightful for our listeners to understand that we have to look at these conditions and these diseases very differently. So, on that note, when you wrote this book, what was the reaction from maybe your colleagues and maybe as well also your patients?
Yeah, Greg, before I do that, let me add one thing on to what you said on the type 2 diabetes. It was interesting. Like I said, I used to think as a doctor, because we're, as a medical doctor, we're trained to think, diseases start and they, you either have the disease or you don't, and it's an on or off switch. And it's sort of necessary the way the insurance system is set up and everything. You can only bill for diabetes once they have the diagnosis of diabetes. And, a year before they get that diagnosis, there's nothing, you're not allowed to do anything because they don't have the diagnosis yet. And I used to think about diseases that way, that, oh, somebody has cancer, somebody has this, and, it's too bad, I help them and everything as best I can. But I realized with type 2 diabetes, it's very interesting. As your audience knows, the primary diagnostic marker, one of them is hemoglobin A1C, it's called, which is a measure of glycation, sugar damage to red blood cells, basically from high sugar levels. And you can actually measure it. And when it gets above a certain point, when it crosses the threshold, you're called a diabetic. And when it's lower than that, you may be a pre-diabetic. And then before that, you're normal. Well, there's a fascinating study just came out of U.S. Non-diabetic adults, and they took large numbers of patients from the Framingham study and from some Ann Haynes data as well, and they looked at hemoglobin A1C levels in non-diabetic adults. And with aging, the interesting thing is the hemoglobin A1C level increases with time. Like, these are non-diabetics, but the older you get, it keeps going up and up and up like that. What does that mean? Well, to me, the way I take that is that insulin resistance, which is what type 2 diabetes is, and the hemoglobin A1C is a marker for that. But insulin resistance and even type 2 diabetes, I now think it's something more like gray hair. In other words, it's something, if I live long enough and if I don't die of something else first, my hemoglobin A1C is going to cross the threshold and I'm going to be, a diabetic. And so that's one other thing to, as an incentive to adopt a healthy lifestyle. It's like, I talk to patients, I go, I'm not going to watch what I eat. I'm not a diabetic. Well, actually, many people, I would say the majority of people with aging face increasing insulin resistance. And, and again, it's the same thing. We can all benefit from a healthy lifestyle. But to your question about my colleagues and how they responded to this, well, honestly, most of them haven't read it. People don't read books anymore. But I think, I think reasonable people can agree to disagree. And, these are not my ideas. This is not my research. All I've done is I've taken the evidence, the studies, and I reference them in the book, and I've interpreted them the best way I can, the most honestly and, thoughtful way I can. And if somebody disagrees with, the interpretation, that's okay. It's like, and I realize that, science is ever changing. It's never settled science. And, I've been doing this long enough to see a lot of changes, and hopefully I'll see a lot more. And even the stuff today that we accept as truth, in a few years, maybe lies also. And we all, hopefully I try to be open-minded. I try and not cherry pick the articles and try and, not do confirmation bias when I read stuff. But, we're all on the journey together. I have no agenda here. If tomorrow they say that Coca-Cola makes us healthier, I will order it by the case and drink it. I used to love Diet Coke. I'm a junk food addict. I'm a recovering junk food addict. So
Yeah. No, thanks for that candid answer. But I must say that I think your book is a fascinating and an important contribution to this conversation. Many of us at D-Life have read it. So yeah, thank you. Thank you for writing it. And
oh,
I think I'm going to
thanks.
pass it back to Shayan.
Yeah, thank
Yes,
you
Shayan,
so much,
please.
doctor. Thank you so much. Just on that front, how did your mom react to the book?
Um, Good question. Sadly, she had passed away
Okay,
before I wrote
sorry
the
to hear that.
book, but I think she was 88, and no, I'm sorry, my dad was 88. My mom was 96, and she had a good life. But it was before I wrote the book. But I think knowing what I know about her, I think she would have been proud and happy to see these ideas get out there, and it would have been great to have a conversation with her about some of these nutrition things and get her take on it all after all these years.
I'm sure about that. Doctor, just last a couple of questions, maybe one quick question to you. You spoke about the fact that you wanted to give back what you learned, and I'm sure you're continuing to doing much more right now. So going forward for future, maybe next 5 years, 10 years, 15 years, what are the areas that you are currently working on, and what is a vision that you want to leave all of us, today as a learning that we should be following going forward?
Well, I want to get this message out about lifestyle and the transformative power that we have in the choices that we make, and adopting the right mindset. And what is coming as a result of that also is there's a revolution in our knowledge about longevity. Now, if we push back these chronic diseases like we talked about, we have increased health span, we have increased lifespan, and that's going to increase how we live longer. And the whole science of longevity is exploding above and beyond just getting lifestyle now. There are things like partial epigenetic reprogramming of stem cells in humans now using Yamanaka factors and similar drugs that a study was just showing a patient took their own pancreatic islet cells, a type 1 diabetic, reprogrammed them back to healthy cells, reimplanted them in their abdomen, and 1 year out, it's only been a year, the patient requires no insulin. And that's a type 1 diabetic, which, as we know, is due to pancreatic failure and immunological reasons. But this partial epigenetic programming, longevity things, I believe, have the potential to increase our lifespan well beyond the 120 years that is sort of the maximum human limit. And it's fascinating how that's going to play out. And lifestyle is certainly a root of it, but it's even growing more and more with longevity. And funny thing, the older I get, the more interested I get in longevity research. But it's amazing. People are discovered a central biological clock in mice in the hypothalamus, that if you lesion it, the mice live less. But if you add stem cells to the hypothalamus, the mice actually live longer. They live longer than the most powerful anti-aging drug, rapamycin. They live longer than that. So now humans, I'm working with a group here in LA with Shelley Jordan, where we take an MR scan of the brain and we localize the hypothalamus in a human. Then we take a laser or ultrasound and we're able to focus it on the hypothalamus and not really open up the blood-brain barrier there, but actually just a milder dose of energy to make the endothelium of the blood vessels open up slightly to let molecules through. Then we inject exosomes into the bloodstream through a venous access, and these exosomes go to this central clock. And the idea is you could reset your central biologic circadian aging clock with these focused ultrasound approaches with into the hypothalamus. So it's just wild stuff, all kinds of things going on. It's so fascinating.
Yeah, actually, it's fascinating. Before we wrap up today, a big thank from Mandara and I, obviously, but I would also like to invite back Anup and Shashi to say some last words or comments that they might have to make.
Yeah.
Maybe-
So
maybe-
while they join, maybe I'll quickly get in a question. So you talked about some of the constraints that you feel or experience from the angle of insurance, etc. So sort of what is the pushback and how does it work when it comes to chronic disease? Because the incentives don't really seem well aligned there.
Yeah, you're asking about insurance incentives with chronic disease and all?
Yes.
Yeah, I mean, insurance, if type 2 diabetic, insurance pays for insulin, it pays for metformin, it pays for surgical amputation, it pays for renal dialysis, it pays for, all these things. It doesn't pay for lifestyle support and diet that will get people off the seed oils, Dr. Shanahan, and also the sugar and all these other things. So that's what we're facing now. But I just want to thank you guys and thank everyone here for the program. You're doing the great work you're doing. It's helping so many people's lives in India and around the world. It's a real honor and pleasure to be part of it. And it's great to see you too, Kate. I'm certainly glad I'm not following you because it would be a tough act to follow. So.
Oh, Shaw, you're too kind. Thank you. I think you're the tough act to follow here. Sir, UCLA.
Dr. Lufkin, thank you very much for accepting the invite and coming and speaking and sharing your knowledge for India, because we desperately need thought leaders like you. And in India, people believe doctors more than anyone else. And when a doctor comes and tells this, and then they tend to believe. That's why in all our conferences, our 90% of the invitees are doctors, and then a few researchers and maybe one or two odd layperson, but most of them are doctors only. And thank you very much. Cannot thank you enough. And maybe we'll call you again in future events and maybe meet you physically also one day if possible. Thank you very much.
It's a real pleasure. Thank you so much.
Thanks, Dr.
Enjoy. Thanks. Bye.
Bye-bye.